Everybody, and welcome to the latest edition of the Lunch and Learn series put on by the Chicago Asthma Consortium. Okay, next slide. All right, so the Lunch and Learn for today is going to be on vocal cord dysfunction. Um, I'm your moderator. My name is Matt Seymour. I'm the executive director of Mobile Care Chicago. We have asthma vans that travel around the city of Chicago and also Lake County, providing free asthma and allergy care to folks, primarily kids, in partnerships with schools. And as a volunteer and as a person with asthma, I serve on the board of the Chicago Asthma Consortium. So Rochelle, who is our executive director, and I work very closely together. So very happy to be with you all today. Next slide. I went over all this information, but I was staring at the sun in this picture. I need to get an updated picture. But we'll just skip this slide and we'll move on to the next one. Okay, so what we're going to be doing today is first we're going to do an overview of the Chicago Asthma Consortium, and that won't take very long. I'll introduce our speaker, Dr. Husain. Dr. Husain's presentation will then happen, and then we'll have a question and answer session afterwards. So as we'll go over in the next slide, you'll be able to put stuff into the chat, and as the moderator, I'll sort of aggregate everything and then ask it once we're done. You don't need your video or audio for the webinar today, so you can turn both of those off. We'll just exclusively be working through the chat. If you have technical difficulties, you can contact Kay in the chat, and she'll be able to help you out. You can also introduce yourself in the chat, and you're welcome to put stuff in there as the presentation goes along. And if you have questions for the presenter, like I said, feel free to put those in the chat, and I'll make sure that we ask your question at the end. We also have an evaluation at the end of the Lunch and Learn. That helps us to just understand what topics you would like to know about, and any other feedback that we can use to make these events better. So we do take all of your feedback really seriously, and we appreciate you filling out the survey. Next slide. So a little bit about the Chicago Asthma Consortium. The CAC seeks to improve the quality of life for people with asthma through advocacy, education, and collaboration. And generally speaking, our overall purpose is to convene a lot of different stakeholders around asthma and make sure that we're able to share information, and that we're all on the same page in terms of asthma policy, education and resources for people who have this disease, especially people living in the city of Chicago, and then ultimately create a high quality of life for people who have asthma and caretakers of people with asthma. You can go to our website to learn more about how you can become involved. That's chicagoasthma.org. And other ways that you can help, you can volunteer in a committee with a number of us who are on the board of CAC, and also just passionate volunteers who help out. We have a community advisory board that interfaces with researchers to give them feedback on different proposals they're developing. We have a community engagement committee that is actively trying to push out resources to folks who have asthma. We have a fundraising committee, a membership committee, and then we also have a professional development committee that is responsible for putting on the forums like this one here. We're also accepting applications to our board of directors through the end of this month. So if you're interested in learning more about a role on the board of directors, you can contact the info email address here, which we'll also put in the chat for more information. And with that, I want to bring in our presenter, Dr. Inna Husain. Thank you for joining us today. Dr. Husain is a board-certified otolaryngologist and fellowship-trained laryngologist specializing in the medical and surgical treatment of upper aerodigestive tract disorders. Her completed otolaryngology head and neck surgery residency from Northwestern, followed by a laryngology fellowship in Massachusetts Eye and Ear Infirmary, and which is a Harvard teaching hospital. Dr. Husain started her professional career as the section head of laryngology at Rush University Medical Center prior to transitioning to community practice to develop the first comprehensive voice, airway, swallowing disorders program of Northwest Indiana. She is currently the medical director of laryngology with Powers Health. She has over 35 peer-reviewed articles and is an international speaker with an active member in the American Academy of Otolaryngology. She is also active on social media as a medical educator with over 250,000 followers. So thank you, Dr. Husain, for being with us today, and I'll turn it over to you to get our presentation started.
Great, thank you so much. Just be sharing my slides. Perfect. Well, Matt, thank you so much for that very generous introduction. I'm so happy to be here to kind of give an overview of this topic. I think this is incredibly relevant for anybody who has had any sort of shortness of breath or healthcare providers and professionals who work with patients who may present with shortness of breath. So as an ear, nose, and throat doctor, kind of may be wondering why I'm talking to you guys today. And the reason is because as a laryngeal expert, a lot of what I do is I manage issues that relate to the vocal folds. And as many of you may know, the vocal folds are essentially the gateway to the lower airway. So air cannot get to your lungs until it has passed through your vocal folds. And so when those vocal folds start essentially acting up, it can contribute to a lot of breathing trouble and problems. And so that's kind of the area I specialize in. We're going to be talking, the flyer said vocal cord dysfunction, and yes, we are still having that talk today, but the nomenclature or the naming in our field has definitely changed over the last few years, and so we don't really use the term vocal cord dysfunction anymore because it was very vague, and we use this term now, inducible laryngeal obstruction. It seems to kind of encompass the condition that we're really talking about so that everyone can be on the same page. Just a few objectives in terms of what I'm hoping to touch in the next 15 minutes or so, kind of a reviewing kind of diagnosis, workup, management of this inducible laryngeal obstruction, which we call ELO for short, kind of understand the relationship of asthma and ELO, and then learn the concept of laryngeal hypersensitivity and how it plays a role in ELO. I just threw this picture in. I'm a second generation ENT. My mom's actually an ENT. So I grew up kind of with a lot of talks about tonsils and ear tubes and vocal cords. And so it's kind of been my background, and I'm really kind of grateful that I can practice it as an adult. So let's start with a common clinical scenario, something that kind of comes to my office often. Essentially, this clinical scenario is a 20-something-year-old runner who's referred actually by her pulmonologist for kind of persistent shortness of breath or dyspnea. Seems to occur when she's around mile 2 to 3 of her daily run, and she feels like she has a really hard time getting air in. Sometimes there's kind of a wheezy quality to the voice, but this feels very different than what she's known as her asthma her whole life. And she comes to me and says, I was sent here because I need a vocal cord check. Okay. So when we talk about inducible laryngeal obstruction, I put this slide up here because this is a condition that has essentially many names. A lot of them vary depending on the geographic location. So in Europe, Australia, they use different terminology than we do here in the States. Different subspecialties of medicine may call this different things. Essentially, it's kind of all the same idea. It has to do with breathing patterns and how the vocal folds are modulating airflow to your lower airway. So all of these terms are kind of essentially the same thing we'll be talking about today. So inducible laryngeal obstruction is essentially a disorder in which someone has otherwise normal vocal fold motion. So at baseline, their vocal folds can open and close like they're supposed to, but this patient is having intermittent episodes where those vocal folds seem to tighten or constrict when they're trying to breathe. When this happens, it gives a sensation of shortness of breath. They may also complain of kind of throat tightness, breathing through a straw, and they may have some version of noisy breathing, such as stridor or wheezing. Now, when we think about kind of normal vocal fold function, we have to remember that there are normal patterns that happen physiologically. And so normally when we take a breath in, the respiratory center in our brainstem makes what's called our posterior cricoarytenoid muscle. It's a muscle of the voice box get activated, and this helps to open the vocal folds. When we want to breathe out or exhale, there is essentially a decrease in that activation, which causes the vocal folds actually to close a little bit. So there's a little bit of tightness that happens normally when we're breathing out. Now, there's certain conditions where some of this overclosure is actually considered physiological. So this is primarily in our patients who have very severe pulmonary disease. So we talk about this idea of the vocal folds really closing when they're breathing out in patients with severe asthma, and this is actually considered a protective mechanism. So by closing those vocal folds with air pushing through, it actually creates a sort of intrinsic PEEP known as positive end expiratory pressure that helps keep airways open. So this is, again, can be physiological, this vocal fold dysfunction or inducible laryngeal obstruction in patients with very severe disease. More commonly, though, we see this in patients without that level of pulmonary disease. So when we think of ELO, to summarize, we're really looking at a condition in which your vocal folds are closing when you really want them to be open. And that's what's creating the shortness of breath. This is just two imagery. If you've never seen the larynx before, this is what the larynx or the voice box looks like, where you have your vocal folds kind of like a gate. They open up, air can go into the trachea. And then when you're speaking, coughing, clearing your throat, those vocal folds slam together and close. And those are kind of the two main functions. So some examples, just some shots of things that I may see in the office. So for example, this is an image of a person blowing air out or exhaling. And what we can see here is that the vocal folds are very, very tight, and they call this a posterior chink. What's interesting is this may present with a wheezing sensation from the throat as opposed to the lungs. The second is an example of a patient trying to take a breath in, and you can see that that gate, or what we call glottis, is not open. So what the patient is going to feel is a lot of resistance in terms of air coming in. They're probably having some stridor, which is a high-pitched noise consistent with upper airway obstruction. Okay. Next, we have kind of the idea of what causes this to happen. So what's the underlying issue here? And essentially what we think what happens is that there are these neuroplastic changes in that brainstem laryngeal control center, which has networks. And essentially what it does is it creates this voice box or this larynx that's in the spasm-ready state. It's very kind of tight and triggered. It's on high alert. It's just waiting to spasm. Now, it's important to understand that normally the larynx is there as a protective mechanism. I tell patients it's a guard dog. It is always looking for any sort of irritation that it needs to protect you against. And how does it protect you? Well, it essentially closes, right? So it's giving you a hug to protect you. It doesn't want anything to go into the lower airway that doesn't belong there. And so this heightened state can lead to increasing issues with things like voice changes, which we call muscle tension dysphonia, patients who have intermittent what's called laryngospasm, that's essentially where the throat feels like it suddenly closes up and it's hard to breathe, or even symptoms like chronic cough and like a globus or a lump in the throat sensation. Okay, so triggers for this, like what can cause this kind of neuroplastic change to occur? We generally think it's any sort of chronic inflammation or irritation that can trigger this. And so we think of things like chronic reflux in both the traditional GERD format or in the silent reflux format. We think any sort of inflammation from the upper kind of sinonasal tract and with inflammatory markers such as allergies, constant exposure to irritants in the needed air can trigger this, and exercise also. Exercise can be very traumatic for the vocal folds because essentially they're working out as well to help modulate how much breath is coming in. And then stress. So anything that causes kind of neurosensory hypersensitivity, vagal nerve activation, chronic stress, depression, those type of things can cause a more sensitive guard dog or larynx as well. Now, how do we diagnose somebody with this inducible laryngeal obstruction? Well, firstly, I look for clues in the history, and this is pretty easy, right? We kind of ask patients, what do you feel when you're short of breath? What seems to be the triggers for it? And a lot of that time, the answers to those questions very much lead us in the direction that this likely is some sort of laryngeal issue as opposed to kind of asthma. So patients often will feel like the neck or the throat feels really tight. They may feel like it's hard to get air in. Sometimes people will say it almost feels like I'm breathing through a straw. The symptoms seem to be triggered by non-traditional things. So scents, emotions, those type of things. Cold air can trigger it. Seems to come on very rapidly and doesn't seem to respond in the same way that normally their asthma responds to. And then also with this, a lot of these patients, sometimes patients find me on their own, but more often than not as a subspecialist, they are referred in. And so they're coming to me with essentially either a negative asthma workup to explain their symptoms or really very mild changes that seem out of proportion to what the patient is describing. When we do spirometry, or if my pulmonary colleagues do it, we're looking for changes in the shape of the breathing. So usually with breathing in, there may be some blunting, which can suggest something outside the lungs causing the shortness of breath. And then finally, kind of laryngoscopy findings, or when we look at the larynx. So the flexible laryngoscopy is basically using a flexible scope to look at the motion of the vocal folds. We're directly looking at that motion to see what they're doing. And it also has the role of ruling out other issues, right? So other reasons why a patient may be shortness of breath, such as upper tracheal narrowing, known as subglottic stenosis, actual vocal cord paralysis or weakness, or even sort of laryngeal mass or something obstructive in that case. Okay, now ways to bring on this vocal fold dysfunction is basically trying to induce it. Now, this can be really challenging depending on the setup that you may or may not have. And so specifically if patients, for example, only have symptoms when they're on mild 2 to 3, well, that's very difficult for me to create that environment here in the office. And so this is actually an example from a laryngologist friend of mine down in Australia, where they've set up this kind of PVFM, also known as ELO lab, where they can have patients go on a treadmill, go on a bike, inhale methacholine while they're undergoing a laryngoscopy to watch those vocal folds and give kind of kind of a confirmatory diagnosis that yes, that shortness of breath, when you feel it, the vocal folds really are constricting. Now, sometimes in the office, we'll do it if patients are triggered by certain scents. So we'll have them bring in perfumes and things like that. I've had patients do burpees in the office before, or walk briskly in the hallway, climb stairs to try to induce the symptoms before we look. This is incredibly important if you refer often to ENT. Not seeing vocal cord dysfunction during a laryngoscopy does not mean the patient doesn't have it, right? So if they weren't feeling shortness of breath when someone was looking, well, of course the larynx is probably going to look normal. So you really have to have a high level of suspicion for this. Asthma and ELO, so there is a large overlap. We do see a lot of patients who have both. And as you can imagine, this often leads to a delay in diagnosis for ELO because they're continuing to be treated for their asthma, which essentially leads to more ED visits, hospitalizations, imaging studies ordered, and a ton more medications. Patients will go through different types of inhalers, allergy pills, all of that stuff in order to get kind of some relief where the diagnosis was never asthma to begin with. Okay. Asthma and ELO, again, we're looking for that discrepancy. So I really rely on my pulmonary colleagues to tell me that, hey, the symptoms seem out of proportion to what their spirometry is showing or how much well-preserved lung function they have. It's also important to understand that not all airway noise is wheezing. Now, patients may call everything wheezing, but as healthcare professionals, we really need to know the difference if we're treating patients with shortness of breath. Stridor is very different and is always related to upper airway, whereas true wheezing is more pulmonary. Laryngeal hypersensitivity. So this is a big part of treating patients. Again, we talked about that the baseline reason that this happens is the larynx, for whatever reason, is trying to protect you more than it needs to. It's that hypersensitivity has been triggered. Now, whether this was an initial inflammatory insult, think of like upper respiratory infections, COVID being one. We saw a lot of this after COVID, which was incredibly inflammatory. And then what happens is you're living the baseline sensitive state, increased tension, that guard dog is just on high alert. And then there's some subsequent stimulation that occurs, such as a strong scent, exercise, a reflux event, and that induces that protective response to make the vocal folds kind of tighten and close. And that causes essentially the airway narrowing and shortness of breath. When we manage these patients, we're really looking to just try to improve their quality of life by improving kind of how much shortness of breath they feel. We want to get them back to the activities that they love. We want to help them be able to manage future exacerbations and have kind of expectations of what, can come and what can happen and how you can control the episode. We want them to get off of unnecessary medications and get back to school and less ER visits in general. Those are our goals. So management strategies. The primary way that we treat inducible laryngeal obstruction is with something called respiratory retraining or laryngeal control therapy. This is done classically with a trained speech language pathologist who does essentially vocal fold or laryngeal exercises and breathing exercises to help retrain this larynx. Remember, that guard dog is super active. We want the guard dog to settle down. And we need to do that by helping to create new muscle memory patterns. We also aggressively need to treat comorbid conditions, so anything that could be triggering more of that hypersensitivity, modify their occupational exposures, if there's any irritants that they're exposed to that could be triggering it. And sometimes if this has been going on a lot, or if patients do have underlying depression or stress disorders, helping to manage those also helps this inducible laryngeal obstruction. So in general, this is not a lecture on the actual techniques that are done, but these are well-documented techniques that are very helpful. A speech language pathologist would go over most of these with the patient to help find the ones that are the most intuitive, the easiest for the patient to incorporate. A lot of this involves exercises that help to open up the vocal folds. So sometimes like things like panting, like I tell patients, if you pant like a dog, you're forcing air in, forcing those vocal folds to open. This is just a quick, I'm going to go through this kind of quickly because I know we're short of time, but this is what a laryngoscopy essentially looks like. So this is what I do in the office where I'm looking here in the middle, you see those vocal folds, and we're seeing this patient and noticing that the patient is very tight. Those vocal folds aren't opening very briskly to allow air, and she's feeling shortness of breath. I'm hearing intermittent stridor during this exam. And so really, really tight. So I sent this patient to do voice therapy and then had a follow-up with her. Sorry, voice therapy meaning the laryngeal control therapy. And what we can see now is that the vocal folds are definitely opening more. There's a cough, but at baseline, she's not having that really tight. The vocal folds are kind of opening. Now she still has to work at it. It doesn't come completely naturally to her, but there we go. When she does those breaths, those vocal folds open up, allowing air to kind of come through and help her breathing. There we go. So open vocal folds. Okay, so patients often ask, they do the voice therapy, feeling better, will this come back? And the truth is, yes, it likely can come back, but this time you have a toolkit to help you through it. So we definitely talk to patients about, any upper respiratory inflammation, allergies acting up, reflux episodes can predispose to the symptoms coming back. So we encourage patients to practice this good breathing techniques even when they're not having symptoms. And sometimes they need to go in for what's called a refresher course with the speech language pathologist. Now, if this fails, what do I do? Well, you kind of start over. Did I miss something in the history? Did I miss something on the laryngoscopy? If patients are seen by a general or comprehensive ENT and this sort of thing fails, they really need to come see a laryngeal specialist for something called a video stroboscopy. It's a more in-depth way to assess vocal fold function. Are we truly optimizing management of these comorbid conditions? The side note to this, I will tell you that not all reflux is controlled with acid suppression, and that's a whole nother topic, but being on something like a proton pump inhibitor does not mean your acid reflux is controlled. world. There's a huge component of these patients who have what we call silent reflux, and so optimizing management of that usually helps. And then finally, how do we incorporate and address laryngeal hypersensitivity if therapy alone doesn't work? So with laryngeal hypersensitivity, we talk about doing what's called laryngeal desensitization. This is essentially using common neuromodulators, so things that work on nerve endings to decrease that sensitivity. That may be medications like gabapentin or amitriptyline. Sometimes I'll inject Botox into the larynx for this to try to reset the system, help some of that tightness. And the newest thing we've started doing is something called a superior laryngeal nerve block. In short, it is adding an anesthetic near the main sensory nerves of the vocal cord called the superior laryngeal nerves to help decrease some of that sensitivity. And then again, working with a trained, psychologist doing some cognitive behavioral therapy can overall help that kind of hypersensitive vagal nerve. So one final thing that I want to bring up. So not all patients who are referred to me with that shortness of breath, abnormal spirometry are truly vocal fold issues. There is a large patient population out there that has this, what we call dysfunctional breathing pattern. It's essentially, classically, patients will describe this difficulty taking a deep breath in. They may feel pressure or chest tightness. And what's interesting about it is it often happens at rest as opposed to with activity. And so a lot of these patients have what we call dysfunctional breathing pattern. The main one is basically a poor diaphragmatic engagement or coordination with taking a breath. And there's a variety of things that can trigger this. I primarily see this as a result of what we call silent reflux. And so I work with patients a lot with that. Speech language pathologists can help patients with this as well, doing what's called diaphragmatic breathing or belly breathing training. But when you suspect this may be happening, it's really important to communicate that to the speech language pathologist so that they can focus their efforts more in that direction as opposed to exercises that cause the vocal folds to briskly open, because that may not be where the issue is. So kind of final takeaways for this, ELO, it's a treatable cause of dyspnea as long as it's identified. It's often a multifactorial disease, right? So what an individual person's trigger, it may be different, but the end result is that hypersensitive larynx. And so I truly believe a lot of what I do is really individualizing treatment for patients and helping them manage comorbid conditions. Failure to recognize this as a source of shortness of breath very obviously leads to increase in healthcare costs and also increased use of medication and hospital visits. When we talk about this, let's not forget the neurosensory component of this, meaning the hypersensitivity component that needs to be addressed, and also looking for any additional kind of dysfunctional breathing pattern that should be addressed as well to get patients feeling better. Okay, well, that is all I have. Hopefully I stayed on time, maybe a little over. If there are, I guess, a few questions, Matt, are you gonna read them off or should
Yes.
I? Okay, perfect.
And yeah, thank you, Dr. Hussein. This is great. Excuse me. So we do have one question from Diana. Besides the flattening seen during inspiration on a spirometry report, are there any other changes seen post bronchodilator spirometry?
Not really. That's the main one. It's kind of that inspiratory loop blunting. And so I would say that if you treat patients for things like asthma and shortness of breath, just having that high level of suspicion, like, does this really sound like asthma? I see a lot of other conditions that cause shortness of breath, such as tracheal narrowing or subglottic stenosis. And very often it's just a matter of like listening to the story. And I'll be very frank about that, like wanting to advocate for patients. Like, is it really asthma when you're 40 years old and you start having shortness of breath and you've been a never smoker, never had allergies? I mean, it's just kind of taking a little question of maybe there is something in the larynx happening that could be contributing to symptoms. So very much the story, listening for any sort of stridor. I've had people refer patients in because they heard wheezing, but it sounded like from the throat and not from the chest, right? So that definitely warrants an examination.
Okay, thank you. And actually, you were getting to the next thing I was going to ask you about. So Andrea had put something in here about that her daughter, who's a high school athlete, has ELO and has asthma and was able to identify the difference. And I was just going to ask how often you see that uh, patients are presenting and they're proactively noticing a difference between uh, certain types of I don't know, like breathing dysfunction versus other types.
I would say I see that more commonly in, frankly, my younger patients. So definitely, like students, young adults, they seem to kind of feel and be more in tune, frankly speaking. I think the challenge is some of our elderly patients, where this develops. They don't necessarily notice that, and I have to really kind of prompt them to say, like, is this your asthma? What triggers it? Remember, there's different types of shortness of breath. But yes, I think the more in tune you are, the more feelings you have, like, just being able to express that and share that, I think is very important.
Okay. And uh, is there any difference in like the pediatric versus adult clinical presentation or treatment approach?
Yeah, so just with my own kind of practice pattern bias, I don't routinely treat children. I'm an adult laryngologist, and so I don't see a lot of necessarily like young children with ELO. I definitely see adolescents, and I'll treat them. And so most of the time, they're the classic textbook athlete with shortness of breath during that activity. So high achieving athletes where this seems to be triggered. So I see a lot of like swimmers, for example, where they're able to do a lot and then suddenly in the middle of their, the swimming, they get symptom onset, which is very different than some of our elderly population, where they're, again, it's not really activity induced because frankly, they're not doing a lot of activity. It just seems very random to them. And for those patients, we really work hard to figure out triggers, really have them keep diaries and that sort of thing.
Thank you. And Sarah also asks, is ELO more common in children born with laryngeal cleft?
That's a great question. I would say that I have not heard that before. A cleft has other different, usually doesn't affect laryngeal function in terms of vocal fold motion. But again, if the cleft is causing things like, for example, aspiration is a huge trigger for laryngeal dysfunction, right? It's a protective mechanism. So there may be some relation there depending on the severity of the cleft.
Okay, thank you. And Dr. Hussein, thank you for staying a couple minutes over
Yeah, of
to
course.
go through the questions. And that's all the questions that we have.
Great.
So
Well, thank you so much. I think I had given my contact information if anyone has any questions.
wonderful, thank you. And just as a little bit of like follow-up information, we do have a couple of events that are coming up. We'll have another lunch and learn on healthy housing. And then we also have another event coming up, managing asthma in schools, specifically for school nurses. So if you know anyone who might benefit from that, please send the link along. And then we also have our World Asthma Day conference, which will be at UIC this year. And that's really a couple different forums that are going to be talking about the state of asthma right now and what we need to do going forward to try to organize ourselves around policy and different approaches to get access to folks who have asthma. Um, so I hope you'll join us for some of those. In the interim, I hope that you'll fill out the evaluation that's in the chat. Please do that, and we do read them and use them to develop our next slate of topics. So thank you everybody for joining. Thank you, Dr. Hussein, again for your amazing presentation. And we'll see you all next time.